So Dr. Burgundy Johnson from the Child Psychology Program is going to be speaking to us today. Thank you.
Yeah, thank you for having me. I have met some of you. I know some of you better than others, and I'm really excited to be talking about this stuff. I've been making the round. So if you've already heard my spiel, I'm sorry that you have to listen to me again, but I'm still excited. Let's see. Can you see my presentation okay?
Yes,
okay.
We can.
I know you can see my speaker notes. I don't have any, so that shouldn't make a difference. So I'm a child psychiatrist. I'm board certified in actually adult and child psychiatry, but my passion is child psychiatry. I came from University of Iowa, so I still live in Iowa City. I'm telehealth. The way that this all started was I have a good friend out there who's a psychiatrist, and she'd been trying to get me to move out there for a while. And my kids, they both have some health problems, and so we're really hooked into the medical community. We see just about every specialist, I think. We didn't really want to move. But then my husband ended up getting a new job. And so then we were going to move. So I left the university and I negotiated a remote job with Carle. So that's how all this happened. Then we ended up not moving. So point is, I'm adjunct at the University of Iowa. So I still do lectures over there all the time. And then now I work at Carle part-time. Remotely. So that's how a lot of people are like, how did you end up over here? So that's my tiny story. But anyway, so I'm the child psychiatry lead in the department. So I'm sort of building the program, I guess you would say. Now we have 3 providers right now. So there's me, there's Annie Robbins, who is an ARNP, and then Allie Wood. She is another child psychiatrist who actually lives down the street from me, that I convinced to join. So she's actually originally from Illinois, and they're thinking about moving there eventually, but her husband has a really good job also in Iowa. They have 2 young kids. And so I talked her into joining, and that's why you have 2 people from Iowa now in this program. And also I'll go over this, but if you guys have any questions during or at the end, feel free to let me know. I'm pretty open. Also, I tell this to patients, I tell it to other people. You can call me Dr. Johnson, you can call me Dr. Burgundy.
Bloomington, Burgundy. Parent and ROSC.
Yeah, I got all those of them on my calendar.
Okay, cool.
Let's see. I think I hear someone talking, right? I'm not just hallucinating. Okay, good. But you can call me Burgundy, Dr. Johnson. I don't really care. The only thing I actually don't like being called, I realized recently, is Mrs. Johnson. For some reason, I would rather be called my first name than be like attributed as being my husband's wife. I don't know why. Like, so it seems like I'm very laid back, but that's the one that, like, I'm not just my husband's wife. You can either call me the doctor or you can call me by my first name is who I am. So anyway, that's my 2 cents. But I don't really get too beat up about what you say. We went over our 3 providers. So I'm part-time. I work Tuesday, Wednesday, Thursday virtually. And then Fridays, I'm on backup call, essentially. If there are any problems that come in, they can contact me. Also, that's my leadership time. So I negotiated leadership time so that I can do things like this, like, reach out to people, set up programs, talk about things. I really think community engagement is big. And so especially as we're building this, I think it's really important. And after the pandemic, that we engage and connect more than maybe we even used to. Yeah. Let's see. So we have our support team right now. Mackenzie is our intake coordinator. And yeah, sorry, they sent us that last minute interview. So I was like, I'll take over, guys. I trust Annie and Mackenzie to pick out someone good for our nurse navigator. So we're a pretty cohesive team, I would say. We're all pretty laid back. We're a team of ladies, so you gotta love that. Anyway, so Mackenzie is our intake coordinator. Lee, so her name is spelled Leah, but it's pronounced Lee, is our child psych nurse. So if you ever have problems or anything, oftentimes these are the people that you'll come into contact with. We also are adding 3 more staff, a nurse navigator, who's going to do basically case management for families, a social worker, and another office assistant. I put it on here. This is often a question I get. What conditions do you see? We see everything. I mean, I was both lucky and unlucky to be at a university for my training, and then as an attending afterwards, where I saw very complex cases for a long time. This, Supposedly there are only 3,800 child psychiatrists in the nation. So we tend to get a lot of people coming from all over. So I'm used to that. So conditions don't scare me. And same thing, I think, for Allie and Annie. Annie's a really good child psych nurse practitioner. And if she ever has questions, we do supervision regularly. So the nice thing is that if you want someone in person, I think she's still like really high quality. So that's my 2 cents, but we see everyone. We'll take all conditions. As of right now, there's nothing we say no to. We might not be able to treat all conditions. If someone wants a child custody evaluation, I might not be able to do the evaluation, but I can still see the kid and do psychiatric treatment. Oh yeah, also with that, for a child psychiatrist, this comes up sometimes. What's the difference between psychiatry and psychology? So we see people for diagnoses, we evaluate them for diagnoses, and then we can continue to do medication management and also referrals. So I have done therapy in the past, but here right now in this role, I'm not doing therapy. Annie has a few therapy cases. So basically, usually what we end up doing is seeing the kids, making diagnoses, and then prescribing a medication, often, not always, and making referrals. That might be to a therapist, to a psychologist for testing, OTPT, things like that. My specialty at the University of Iowa, where I was at, was preschool mental health and also attachment theory. Those were sort of my academic niches, you could say. So the way we tend to split kids is I'm very comfortable with the younger ones. I like working with families. I believe in family psychiatry, trying to get everyone on the same page and family therapy. So that's what I tend to do is I tend to see the younger kids on average. Whereas if we get older kids, they might go to Annie or Allie. That being said, we still all see, all ages. I have 17-year-olds, they have 3-year-olds, but that's sort of how we do the rough split. Okay. So I just mentioned our ages are 3 to 18. Am I talking too fast, by the way? Yeah, okay, good. 3 to 18. Insurance, we take everything. Medicaid, Blue Cross. The only things we don't take are Aetna and United Behavioral Health, which is like a special additional one. Most people haven't even heard of people having these. So it's not, I think out of our 1,000 referrals or something we've gotten, we've turned away one because of insurance and because they had Aetna. So state paper, if they have the state insurance or whatever, we take it. It's generally free for those people that we see. I have not seen anyone with Medicaid get a bill. So that's pretty good. One thing that I am very proud of that I negotiated for when I came here is I believe in spending time with people. So you'll hear me say this over. I'm sorry to be so egotistical about this, but we have long appointments because I think we should spend it with the family. So our follow-ups are 45 minutes and our new patient appointments are 90 minutes. Now, if a patient doesn't need it for that long, then we don't have to spend that time. But I think we all believe in psychoeducation, spending the time that the patient needs. It's not like an in and out experience. Let's see. Right now for referrals, it's only provider referral. So basically it can be any provider. It can be their PCP, their therapist, OTPT, whatever. So that's what so they have to put in the referral first. We're trying to move to a place of self-referrals so that we can take down one of those barriers. We basically just got approval by management to do that because as a whole, I guess in Carle, they prefer referrals. But if you ever have any questions, if you're ever this person doesn't have a doctor or they can't make the referral, let me know personally and I'll get them on the schedule. The way the intake works is basically the provider makes the referral. And then what happens is this all has to happen through the MyChart or portal. So it's all the virtual access to Carle. So if there's no portal set up, Mackenzie will call the family to set it up with them. If they really don't know how to set it up, she'll have them come into her office and physically do it for them. So it's hopefully not too difficult. We're also working on getting Zoom accounts set up so that if people for some reason have difficulties logging in, that's a barrier to setting it up. They can't come in for some reason, then we'll be able to send them Zoom links. So even though it'll be virtual, we're trying to break down the barriers. Also, if someone really can't do virtual, then they can always come in and see Annie. She's doing things in person. Like I said, she's great. Then what happens? So the portal gets set up, or maybe they already have the portal. Then what happens is once the portal is set up, the individual or the family is sent the paperwork on the portal. So it's a packet of information. We've tried to really, we used to have a longer packet. We're trying to reduce barriers, so we made it shorter. I think it's 4 or 6 pages, but it's primarily like, you know, what are your main concerns, family history, social history. It's sort of the basic stuff that people already ask at offices, but maybe a little bit more psych oriented, you know, so any DCFS involvement right now, any guns in the home, things like that. Also, we're not going to kick a patient out because they have a hard time filling it out. All I ask is that parents or guardians or whoever fill it out the best they can. So this is really not meant to be a like difficult process for them. I'm not trying to like gatekeep. It's more of just, we try and get all the information so that we can have a really good visit. And I know, so I've had this argument with the doctors here, not in a mean way, but sometimes when they make the referrals, they're like, all the information is in the chart. And I look, and I should tell you that I think the pediatricians here are great. They've told me that on average, they spend 7 minutes with the patient. So all the information we need is usually, even though they say it, it is not actually in there. Not because they're doing anything wrong, but I just don't expect them to get all the information to make a complicated psych evaluation in there. So people, this comes up, the intakes, the, you know, the barriers and all that. So I want you to know if there's ever a problem along the way, you think for a family, they don't speak English, they're homeless, they're substance abuse problems, they're anything, and you feel like the patient that you want to refer just can't do this intake process, you don't even need to give me a real reason. You can just tell me, can you get them in? And I will. So I think 75% of people should be able to do this. We try to put the packet at 3rd grade level or lower. So I think most people can. Now, if they can't though, I am fully willing to jump the process. If you think there's someone that needs to get in sooner and we don't have an appointment, please, anyone can reach out to me and say, I really think this person needs to get in sooner and later, and I'll add them onto my schedule at a lunchtime. So we're trying to be as accessible as we can be. So anyway, now I'm jumping all over. So the process, the packet gets sent, and then the person has to fill out the packet, send it back to be scheduled. That's the average process, is they fill out everything and then they get scheduled. Like I said, you can jump the line if you want me to just schedule them without getting the packet back. What I found is that sometimes, so the thing is, psych things, a lot of times parents end up processing in the moment. So a lot of times they don't necessarily have a cohesive way of explaining right away. And I don't expect them to. So, you know, if there's been trauma, there's been abuse, there are a lot of things going on. What I like for the packet is not only to get information, but it helps people organize their thoughts, to be honest, so that when we have a visit, it's more effective. Anyway, then we get the packet in, then the staff reach out to schedule the patient, and then they're scheduled. Right now, our wait list is like maybe, or our wait is like a week, maybe less than a week. So if you have a patient fill out the packet today and they get it in, they might theoretically be able to get in tomorrow. I had one today that missed the appointment today because she had a hard time setting it up. So I got her in tomorrow morning. Okay. We're trying to really like come at it from a place, not like a big corporate organization. I think my team is really cares about kids and mental health a lot. So we really try and be committed to, we're trying to be committed to evidence-based care, working with families, working with kids, you know, so if it takes a little bit extra, I think we're all willing to do that. Contacting other family members, contacting schools, going to IEP meetings, I'm willing to do any of that. And that's it. That's my whole spiel.
Does anybody have anything that they are thinking about? I was going to ask about providers. If you know of somebody in your network that you're thinking needs to be referred, is there a provider that they would suggest that they see first if there has to be a referral, or if there should be a referral? And then I really appreciated the fact that it was at a 3rd grade level. That really does help with the barriers that are provided. Anybody else?
Sorry about that.
No, I was just saying my thoughts, Dr. Johnson, was just, do you have a provider? Like if we think we know of somebody that we would like to go through the proper channels, and is there a provider, or is there a group of providers, or what's the best, most likely scenario to get to you?
Usually family doctor.
Okay.
So the person's pediatrician or family doctor. That's
okay.
the way normal referrals come through.
Okay. And
And I
is
have
it,
it on here somewhere. So basically, no, I have it here. So providers, all they have to do is a basic referral. So it just has to have the patient's like the demographic information. If they can send like the last note, and that's about it. And the chief concern, that's all it takes is to fax that.
and is it appropriate to talk to the doctor specifically that you want to possibly go into the psychiatric program?
Say that again. Oh, say that again?
Is it appropriate, like if you really, the outcome is you would like your child to be seen, is it appropriate to let the doctor know that to kind of expedite it? He
Yeah.
doesn't have to guess what you want. Yeah.
Oh, yeah.
And
So
then,
I can't say what everyone's relationship is with their doctor or whatever. It's hard
Mhm.
because there's a lot of narcissism in doctors, if I'm being very honest. And so some doctors maybe don't like to be told what to do, but I have found for the most part, people in this area being very open to a patient saying, hey, I want to see a psychiatrist. I heard about a new one. And then the doctor putting in a referral. For the most part, they seem happier that we have an additional resource.
Right. And then my other comment was, thank you for the 3rd grade level for the packets. I think that is really great. So,
Thank you.
I'm opening the floor. Anybody else have anything? Does anybody else have any questions?
Angie does, it looks like.
Yes, thank you. Thank you, Dr. Johnson. Very informative.
Thank you.
2 questions. One, do you take any clients on sliding scale?
So we don't have a discount, but we do have it's not a discount, but we have certain prices for people who pay out of pocket. And they can get those numbers. So what they do is usually someone has to reach out to me for the billing code, and then I give them the billing code that I would charge, which is it's always a 90897 or something. I have to look it up, but it's always one code that I charge for the evaluation. And then they call our billing department and they see what the cost is. And the last time I had someone who had to do that, the initial visit cost them about $350.
Okay.
That was for evaluation. For follow-up, it was much cheaper.
I will just say that it's less than $350, the follow-up.
Yes.
And my second question, being a counselor in the area, if I have someone on my case, though, can I call you or someone directly like, hey, I'm seeing this individual, I'm thinking Vyvanse. Okay.
Just email me. Yep, my email, it'll be on here.
Okay.
But I'll also put my email in the chat. Feel free to email me at any time. I'm pretty loose with my email, so you can always tell patients to email me too. I don't mind. Here, let me put it down here. What I always say too is I'm pretty quick with email. If you don't hear from me the next 1 or 2 business days, write me back because I may have missed it. I don't work Mondays, so I don't always respond on Mondays, but I'm pretty bad at looking at my email, so I usually do. So yeah, 2 days. If you don't hear anything, write back. That's all I would say.
And the subject line, sorry, last question, like medication question or anything specific in your subject line? No. Okay.
Nope. No, I look at all the emails.
Okay.
You can be like, hey, remember me? I was that person that asked this question. And now I actually have that referral. And I'll be like, yep, I remember.
And then Sonia asked if would we be able to get this PowerPoint for future reference?
Oh yeah.
Okay.
Yeah, I sent it earlier to Jessica, but I deleted one slide. Actually, if you still have it, Jessica, that one's pretty up to date. I just tried to make it even less touchy-feely than it already is. I'm like, I should be more professional. So I took out slides about how we love kids or something, but that one has all the up-to-date information pretty much.
Okay, we'll send that out with our recording.
Okay.
That'd be great. Thank you.
Yeah.
Dr. Johnson's email is in the chat.
Mhm.
Anybody else have any questions? I think it was great information. I think we all know kids are suffering right now, and we all want them to be helpful because they are our future. And I was in a behavioral health summit when they were talking about how to see the health of a nation, you need to see the health of the children. And if they're not healthy, your nation isn't healthy. And so you need to, in your community. So for our community to be healthy, our future to be healthy, we have to look to our children first. So
Yeah, that's a great way of putting it. I
Yeah.
totally believe that.
Yeah.
The one other thing is, and I've said this at other meetings, so speaking of being approachable, so I always talk about to people that this is like a passion of mine and professionally a passion, but I also say personally it is as well. I grew up in a pretty tough family, like DCFS was involved. My dad died of alcoholism a year ago, and then my sister actually killed herself on the anniversary of his death, and she was 23. So a lot of this stuff is like, it's personal, you know? So, I mean, I wouldn't necessarily tell all patients that, of course, if it came up, but I'm not trying to put my stuff on them. I try not to be the like, the doctor who doesn't get it, you know what I mean? Because I do get it.
yeah.
That's my 2
Right.
cents.
Yes, and we all have trauma. Not, yours is very, very heavy trauma, but we all have
Yeah.
something that we can understand a little bit of what they're going through. So thank you, Dr. Johnson. We would love for you to stay. You're welcome to leave. We're gonna do just little shout outs from our individual organizations. But we really appreciate it. And you should be hearing from several of us, I know. And I had several people say, please send me the recording. So there's a lot of interest. So thank you so much for getting
Yeah.
that word out. Yeah.
Thank you. I'll stay here till 12:45 when I have my patient appointment. I want to hear what everyone does. So this will be good for me.
Perfect. Well,
Thank you.
our reigning queen is here, Miss Dorothy. And so I'm going to turn the meeting over to her, and we will see what everybody has to contribute.